Welcome to the deep dive. Today, we're really getting into it with a core topic from medical surgical nursing,
hmm
fluid and electrolyte balance. It sounds simple, maybe, water and salt.
Right, but it's so much more. It's the physics, the chemistry.
Right.
It's what keeps, well, everything running at the cellular level.
Exactly. So our goal here is to kind of give you a shortcut through this complex stuff. We're drawing directly from a key chapter.
Yeah, and the text really frames it nicely. Fluid and electrolyte balance, that's the main concept.
Okay.
And when things go wrong, the big example they use is dehydration,
Right, dehydration.
which immediately hits perfusion. If the volume isn't there, the circulation just can't keep up. That's the critical link.
Makes sense. Okay, so let's break down the system, starting with the basics.
Uh-huh.
We've got water, that's our solvent,
Yeah.
and then the stuff dissolved in it, the particles, those are the solutes.
And some of those solutes have an electrical charge, positive or negative.
The electrolytes, or ions.
Exactly. Keratins are positive, anions negative. Simple as that.
So where does all this fluid actually live in the body?
Good question. Most of it, about 2/3, is actually inside your cells. That's the ICF, intracellular fluid.
Inside the cells.
The other third is outside the cells. That's the ECF, extracellular fluid. And that ECF includes, your blood plasma and the fluid between the tissues, the interstitial fluid.
Got it. So ICF and ECF, how does the body manage where the water goes between these?
Well, there are three main processes controlling that movement. Physics, basically.
Okay, physics. Let's start with number one.
First up is filtration. Think of it as water pushing pressure.
Water pushing, okay.
The technical term is hydrostatic pressure. Water naturally moves from an area where the pressure is higher,
To where it's lower. Makes sense.
right, across a membrane that lets water through.
So clinically, where do we see this?
Your blood pressure. That's the biggest hydrostatic force filtering fluid out of your capillaries all the time. But think about right-sided heart failure. If the heart isn't pumping effectively, pressure builds up in the veins, right?
Yeah, it backs up.
Exactly. And that increased pressure forces extra fluid out into the tissues. That's edema. That swelling you can see, pure filtration happening too much.
Wow, okay. So that's filtration water pushed by pressure. What's next?
Next is diffusion. Now we're talking about the solutes, the particles.
Okay, particles this time.
They move down their concentration gradient. So from where there's a lot of them.
To where there's less of them, like spreading out.
Precisely. Think about oxygen moving into your cells. That's diffusion.
But cell membranes aren't just open doors, are they?
No, definitely not. They're selective. Take sodium, Na plus Da. It's super concentrated outside the cell in the ECF, way lower inside.
How does it stay that way? Wouldn't it just diffuse in?
You'd think so, but the membrane is pretty impermeable to sodium. Plus, you have these active sodium pumps.
The sodium-potassium pump.
That's the one. It uses energy to constantly push sodium back out, working against that gradient. It's fundamental for nerves and muscles.
Okay, so sometimes diffusion needs a little help.
Exactly.
Thank you.
That leads us to facilitated diffusion. Glucose is the classic example.
Oh, wait, sugar.
There might be tons of glucose outside the cell, a really steep gradient, but it can't just cross the membrane on its own.
It needs insulin.
It needs insulin to act like a key or a helper to get it across. Even with the gradient pushing it, it needs that facilitation.
Okay, filtration for water pressure, diffusion for particles. What's the third one?
The third one is osmosis. And this one is only about the water.
Just water.
Just water moving across a semi-permeable membrane. And why does it move? To try and equalize the particle concentration on both sides. To reach osmolarity, equilibrium.
Osmolarity, that's the concentration of particles.
Exactly. The normal range in the body is pretty tight, like 270 to 300 millis per liter.
And this is why IV fluids are so specific.
Absolutely.
Yeah.
If you give an isotonic fluid, like 0.9% saline, its osmolarity is similar to your blood. So not much water shifting happens.
Okay.
But give a hypertonic fluid, something really concentrated, like 3% saline.
More particles than blood.
Right. So water gets pulled out of the cells into the ECF to try and dilute that concentrated fluid. Cells shrink.
And hypotonic, less concentrated.
Yep, like 0.45% saline, half normal. Now the ECF is dilute compared to the cells. So water moves into the cells to balance things out. Cells swell.
Wow, that's powerful.
It is. And it's also linked to your thirst drive. If you sweat a lot, you lose water, your ECF gets more concentrated, higher osmolarity.
Okay.
Osmoreceptors in your brain actually shrink because water leaves them, and that shrinkage triggers the feeling of thirst. It's your body saying, hey, dilute me.
All right, so we've got the physics down, filtration, diffusion, osmosis, but who's coordinating all this on a bigger scale, keeping the overall volume right?
Now we get into the hormonal managers. The big one, the body's first line of defense against low volume or poor perfusion, is the RAAS.
RAS, renin-angiotensin-aldosterone system.
That's the one. It gets triggered anytime the kidneys sense danger to perfusion.
Like what kind of danger?
Low blood pressure, low blood volume, maybe from dehydration, or bleeding, low oxygen in the blood, even low sodium levels. The kidneys notice.
And what do?
They secrete an enzyme called renin, and renin starts a chain reaction.
Okay, a cascade.
Yep. Renin leads to angiotensin the first, which then gets converted, mostly in the lungs, by an enzyme called ACE into angiotensin the second.
Angiotensin the second, I've heard of that. What does it do?
Two main things, very quickly. First, it's a potent vasoconstrictor.
So it squeezes blood vessels.
Right, tightens them up to raise blood pressure immediately.
Yeah.
Second, it tells the kidneys to hold on to water so you make less urine.
Conserving volume.
Exactly. But angiotensin the second does one more crucial thing. It signals the adrenal glands, which sit on top of your kidneys, to release aldosterone.
Aldosterone, the water and sodium saving hormone, right?
That's the perfect description. Aldosterone specifically tells the kidneys, reabsorb sodium, pull it back into the blood, and where sodium goes,
Water follows.
water follows. So you save both sodium and water, boosting blood volume and improving perfusion. It also causes potassium to be excreted in the urine.
Which is why drugs that block this system, like ACE inhibitors or ARBs, are used for high blood pressure. They interrupt this whole cascade.
Precisely. They stop that volume expansion and vasoconstriction.
Are there other hormones involved besides RAAS?
Yes, a couple of other key players help fine-tune things. First, there's ADH, antidiuretic hormone, also called vasopressin.
Antidiuretic, so it stops urination.
Pretty much.
Yeah.
But it's triggered differently than RAAS. RAAS responds mainly to low volume.
Yeah.
ADH responds to high osmolarity.
So when the blood is too concentrated, too salty.
Exactly. ADH is released from the pituitary gland in the brain, and it tells the kidneys to reabsorb just water, not sodium. Its goal is purely dilution.
Okay, so RAS saves salt and water for volume. ADH saves just water for concentration.
You got it. And then there's a system that does the opposite.
The opposite, like getting rid of fluid.
Yep. The natriuretic peptides, NPs. These are hormones released by the heart itself, specifically ANP and BNP.
When would the heart release those?
When it gets stretched too much, like when blood volume or pressure is too high.
So when there's fluid overload.
Exactly. NPs basically work against aldosterone. They tell the kidneys to excrete sodium and water.
So they lower blood volume and take the pressure off the heart.
Precisely. They're the body's natural off switch for volume expansion when things go too far.
Okay, this is great. We understand the movement, the regulation. Now let's talk about when it goes wrong. Let's start with a core example. Dehydration.
Right, or hypovolemia, low volume.
Oh.
Usually it means fluid intake or retention just isn't enough to meet the body's needs.
And typically we're losing fluid from the ECF, right? The plasma and the interstitial space.
Yeah, the most common type is isotonic dehydration, where you lose both water and electrolytes proportionally from the ECF. The big problem is that loss reduces your circulating blood volume,
Which means?
reduced perfusion. Tissues don't get enough oxygen and nutrients.
Who's most at risk for this?
The text really highlights older adults. They just naturally have less total body water to begin with.
Right, less muscle mass.
Exactly. Plus, their thirst sensation often decreases. They might be on diuretics or laxatives. Lots of factors stack up.
So what cues should we be looking for? How do we recognize dehydration?
Okay, assessment is key.
Yeah.
The single best indicator, day to day,
Daily weights.
daily weights. You have to remember this conversion. 1 liter of fluid loss equals about 2.2 pounds or 1 kilogram of body weight lost.
Wow, okay. That's a direct link. What about vital signs?
Cardio-wise, the body tries to compensate for the low volume, so the heart rate goes up.
Trying to circulate what's left faster?
Right. But the pulse feels weak, maybe thready. Blood pressure might be okay initially, but it can drop, especially when they change position.
Orthostatic hypotension. Big fall risk.
Huge fall risk. You'll also see flat neck veins, even when they're lying down.
What about skin? The classic tenting.
Yeah, poor skin turgor. But a safety point here. For older adults, checking turgor on the back of the hand isn't reliable due to natural skin elasticity loss.
So check where?
Check over the sternum or forehead. It's more accurate.
That's a good tip. And urine.
Urine output will be low. Less than 500 milliliters a day is a big red flag. And the urine itself will be dark, concentrated. High specific gravity, over 1.030.
And labs. What would they show?
Think about it.
Yeah.
You're losing more water than particles.
Yeah.
So everything left behind gets more concentrated.
Hemoconcentration.
Exactly. Hemoglobin, hematocrit,
Ugh.
serum osmolarity, glucose, electrolytes.
Mhm.
They all look falsely high because the water component is missing.
Okay, so we recognize the cues. What actions do we take? What's the management?
The main goals are simple. Restore that fluid balance and prevent injury, especially falls.
How do we restore fluids?
For mild cases, pushing oral fluids might be enough, maybe oral rehydration solutions. For more severe dehydration, it's IV fluids,
Like normal saline?
often crystalloids like normal saline,
Eh?
sometimes colloids depending on the situation. The key is close monitoring,
What are we monitoring closely?
pulse rate and quality and urine output. The text says check them at least every 2 hours during rehydration. You want to see that pulse strengthening and urine output picking up.
And safety.
Huge priority. Prevent those falls from orthostatic hypotension. Teach the patient to get up slowly, ask for help every time. Keep the call light and reach.
Okay, that covers dehydration. What about the flip side, fluid overload?
Right, hypervolemia. Too much body fluid, again, usually in the ECF space.
So now the problem isn't concentration, it's...
Dilution. Hemodilution. Too much water dilutes the electrolytes and proteins in the blood, and just too much volume everywhere.
Assessment cues. Still wait.
Weight is still critical, but now we're looking for rapid gain. The text gives a useful guideline. Each pound gained after the first half pound likely means about 500 milliliters of fluid retained.
Okay. And cardiovascular signs. Opposite of dehydration.
Pretty much. Instead of weak and thready, the pulse is bounding, full. Blood pressure is elevated. Neck veins are distended, easily visible. Hand veins, too.
What's the biggest danger with overload?
Respiratory. All that extra fluid can back up into the lungs. Pulmonary edema.
What does that look like?
Increased respiratory rate, shallow breaths, shortness of breath, and the key finding on auscultation. Moist crackles in the lungs.
Crackles. Fluid in the airways.
Exactly. And you might see pitting edema, especially in dependent areas like the legs and feet. Skin looks tight, maybe shiny.
Labs would show the dilution, right? Low H&H, low protein.
Correct. Hemodilution.
What's the priority for managing overload?
Respiratory status is paramount. The text calls it a critical rescue priority. Assess for pulmonary edema signs, those crackles, bounding pulse, maybe decreasing urine output if the kidneys are failing every 2 hours.
And if it's worsening?
Notify the provider or rapid response team immediately. This can deteriorate fast.
So treatment involves getting rid of the excess fluid.
Right. Drug therapy often involves diuretics, especially loop diuretics like furosemide, Lasix.
Makes you pee out the extra fluid.
Yep. Plus nutrition therapy, restricting sodium intake, maybe fluid restriction too.
And safety. Different concerns than dehydration.
Different, yes. With edema, the skin becomes fragile, prone to breakdown. So meticulous skin care, pressure-relieving mattresses, turning the patient every 2 hours. Those are key safety actions. All right, let's dive into the electrolytes themselves now, starting with the big ones. Sodium Na plus A.
Okay, sodium. We said it's the major cation outside the cell, in the ECF.
Right, its main job is controlling ECF osmolarity. And remember,
where sodium goes, water follows. It drives fluid shifts. Crucial for nerves and muscles too. Normal is about 136 to 145.
Perfect. So what happens when it's low? Hyponatremia, less than 136.
Low sodium means low ECF osmolarity, so water moves.
Into the cells, causing them to swell.
And if brain cells swell?
That's the biggest concern. Cerebral changes. Acute confusion is a major sign, especially easy to miss or misinterpret in older adults. Also, general muscle weakness. You even need to check respiratory effort because diaphragm weakness can happen.
Wow. How's it treated? Just give salt.
Depends on the cause and severity. Sometimes fluid restriction helps if it's dilution. Often it's IV saline. For severe symptomatic hyponatremia, they might use small amounts of hypertonic saline, like 3% or 5%.
The really concentrated stuff we talked about?
Exactly. But it's risky because it can shift fluid too fast. It absolutely has to be given slowly, controlled by an infusion pump with frequent monitoring.
Okay. What about high sodium? Hypernatremia above 145.
Now, the ECF is hyperosmotic, too concentrated, so water gets pulled out of the cells.
Cells shrink. Opposite effect.
Right. This leads to increased cell irritability. So the signs are often neurological again, but different. Altered mental status, maybe agitation, confusion, short attention span.
Irritability, like muscle twitching.
Yes, muscle twitching is an early sign, but as it gets worse, that can progress to muscle weakness and reduce deep tendon reflexes.
So treatment is about diluting the ECF.
Usually, yes. Fluid replacement is key, often isotonic saline first to restore volume, then maybe hypotonic fluids like D5W or half-normal saline to gradually lower the sodium concentration. Sometimes diuretics are used if kidney function is okay to help excrete the excess sodium.
Okay, that's sodium. Now for potassium, K plus T, the major inside the cell cation.
Correct, and absolutely critical for excitable tissues, nerves, muscles, and especially the heart. Normal range is tight, 3.5 to 5.0.
So low potassium first, hypokalemia, less than 3.5. What's the effect?
Low potassium makes cells less excitable, they become less responsive to stimuli.
And the biggest danger there is?
Respiratory. The text emphasizes this. Shallow respirations due to respiratory muscle weakness. That's a life-threatening risk. You need to assess respiratory status every couple of hours.
Okay, respiratory is number one. What else?
Skeletal muscle weakness in general, a weak, thready pulse. And GI muscles slow down, too hypoactive bowel sounds, constipation, even risk of a paralytic ileus, where the bowel just stops moving.
And the heart ECG changes.
Definitely. Things like ST segment depression, flat or inverted T waves, and prominent U waves.
Treatment is potassium replacement, right? But you mentioned safety concerns earlier.
Huge EE safety concerns. IV potassium chloride, KCl, is a high alert medication
Why?
because it can stop the heart if given too quickly or in too concentrated a form. It must never be given IV push, never IM or subcutaneous. The severe tissue irritant can cause necrosis.
So how is it given IV?
Slowly, very slowly. Maximum recommended infusion rate is usually 5 to 10 milliequivalents per hour and should never exceed 20 per hour. And it has to be well diluted. The text says no more concentrated than 1 milliQ of K plus per 10 millil of solution. Always on an infusion pump. Always check kidney function first.
Wow. Okay, that's critical to remember. What about high potassium, hyperkalemia above 5.0?
Now we have the opposite effect. Increased cell excitability. And the organ most sensitive to this is, again, the heart.
So cardiac problems are the main risk.
The most severe risk, yes. Hyperkalemia interferes directly with heart function.
What kind of changes?
Bradycardia, slow heart rate, hypotension, and very specific ECG changes. Tall peak T waves are classic. Also, widened QRS complexes. This progresses towards heart block, ventricular fibrillation, and cardiac arrest. It's incredibly dangerous.
Tall peaks T waves. Got it. What about other systems, neuromuscular?
Early on, you might see twitching or tingling, like pins and needles, especially in the hands, feet, and face. But as it worsens, this actually progresses to flaccid paralysis, starting in the arms and legs and moving up.
And the gut. Opposite of hypo.
Right. Hyperactive bowel sounds, cramping, diarrhea are common.
What's the immediate action if you suspect severe hyperkalemia?
The text flags this as a critical rescue. If you see cardiac changes, heart rate below 60, or those peaks T waves, you notify the rapid response team or provider immediately. Stop any potassium infusions or supplements right away.
And treatment. How do you lower it?
Several strategies. You can try to enhance potassium excretion using diuretics if the kidneys work. You restrict dietary potassium. And importantly, you can temporarily shift potassium out of the blood and into the cells.
How do you do that?
IV glucose and regular insulin is a common way. Insulin helps pull potassium into the cells along with glucose. It's a temporary fix but buys time. Okay, let's quickly touch on two other important electrolytes often linked to potassium. Calcium first, K2 plus take.
Calcium. I think of bones, but it does more, right? Normal is 9.0 to 10.5 milli-GLD.
Absolutely. It's crucial for stabilizing excitable membranes, nerve impulse transmission, muscle contraction, and bone density. It's regulated mainly by parathyroid hormone, PTH, and calcitonin.
So low calcium. Hypocalcemia below 9.0, what's the effect? If it's a stabilizer, then low levels mean?
Increased excitability. It actually allows sodium to move more easily across membranes, making nerves and muscles hyper-responsive.
So what does that look like?
Often starts with paresthesias, that tingling or numbness feeling, especially around the mouth, hands, and feet, muscle cramps, and then the two classic signs.
Trousseau's and Schwastek signs?
Exactly. Trousseau's is when you inflate a blood pressure cuff on the arm and the hand goes into this characteristic spasm, carpal spasm.
Okay.
And Schwastek's is tapping on the facial nerve just in front of the ear, causes a twitch in the facial muscles on that side.
Memorable signs. Any safety issues specific to low calcium?
Yes, especially if it's chronic. The bones can become brittle. So the text highlights using a lift sheet when moving the patient to prevent fractures. Also, because they're hyperexcitable, reducing environmental stimuli noise, lights can help prevent seizures.
Okay. High calcium. Hypercalcemia above 10.5. Opposite effect.
Opposite effect. Decreased excitability. Membranes are overstabilized, need a stronger stimulus to respond.
So symptoms would be less activity.
Right. Severe muscle weakness, decreased deep tendon reflexes, slow GI motility leading to constipation. And on the ECG, you might see a shortened QT interval. Also, higher risk of blood clots.
Treatment for high calcium.
Rehydration is key, often with IV saline to dilute the calcium and promote excretion. Diuretics like furosemide can help flush it out, and drugs that stop calcium from being released from the bones, like bisphosphonates.
Okay, last one. Magnesium Mg2 plus normal is 1.8 to 2.6 μQL.
Yep, mostly stored in bones and cartilage. Crucial for lots of enzymes and very important for heart muscle function. Its levels are often related to potassium and calcium levels too.
Low magnesium, hypomagnesemia below 1.8. Similar effects to low calcium and potassium. Increased excitability.
Generally, yes. Increased membrane excitability. This increases the risk for hypertension, coronary artery spasm, and cardiac dysrhythmias again. Things like prolonged QT intervals, risk of torsades de pointe.
So hyperactive reflexes again, maybe Trousseau's and Schwasteck's?
Can happen, yes,
Yeah.
especially if calcium is also low. Treatment is typically IV magnesium sulfate, MgSO4.
Any safety concerns with giving magnesium 4?
Yes. You have to monitor deep tendon reflexes frequently, like hourly, during the infusion. If the reflexes become weak or disappear, it means you're pushing them into hypermagnesemia. You need to stop or slow the infusion.
Okay, so that leads us to hypermagnesemia above 2.6. Reduced excitability, right?
Severely reduced excitability. This is less common, usually seen in kidney failure or overuse of magnesium-containing antacids laxatives.
What are the signs?
Bradycardia, hypotension. ECG might show prolonged PR interval, widened QRS complex, and the key finding is reduced or even absent deep tendon reflexes.
Like when treating hypomagnesemia too aggressively.
Exactly. Plus, profound skeletal muscle weakness. This can lead to respiratory muscle depression and cardiac arrest if it gets severe enough.
So treatment is basically stop the magnesium.
Stop any magnesium intake. Maybe use diuretics if kidney function allows. In severe cases with cardiac problems, IV calcium might be given as an antidote to temporarily reverse the effects on the heart. #outro.
Wow, okay. We have covered a lot of ground there. From the basic physics of how fluid moves, filtration, diffusion, osmosis,
To the big hormonal controllers like RAAS, aldosterone, ADH.
and then into the clinical pictures of dehydration and fluid overload, plus the key signs and safety issues for imbalances of sodium, potassium, calcium, and magnesium. It's a complex interplay.
It really is. And the central safety theme that runs through it all is pattern recognition. Fluid issues hit perfusion and cardiac status, so watch that pulse, BP, weight. Electrolyte issues hit excitability, watch neurostatus, reflexes, and especially the heart.
And that potassium 5e warning.
Absolutely bears repeating. Slow, diluted, pump-controlled, never push IV potassium. It's just too dangerous. Vigilance with infusions and monitoring for those cardiac signs in both hypo and hyperkalemia is just critical. Same goes for watching for pulmonary edema in fluid overload.
So thinking about how interconnected all this is, here's a final thought to leave you with. We talked about RAS kicking in to compensate for low volume, sometimes before obvious symptoms appear.
And it's trying to hide the deficit.
So if your patient starts, say, a new diuretic, something that makes them lose fluid, what single simple piece of daily information that we discussed is probably your earliest, most reliable clue that the RAS system has been activated and is working hard to compensate even before they feel dizzy or their BP drops significantly?
Something to really mull over.
Yeah.
How do you catch that subtle shift early?
Exactly. Keep thinking about those connections, the trigger, the body's response, and the subtle data points that tell the story.